Hello students. Today we will discuss about the umbilicus and its importance. Now this is a very commonly asked question in your exam, and most of the times students are having the complaints that they don't know how to write this short note or how to attempt this question in exam. So today we will discuss what are the different parts of this question and how to write and which are the important points which you have to cover when you are writing the question. So before that, you should know about the introductory part of the umbilicus, which has to be there in your exam questions, that this umbilicus is actually a scar, and this scar is actually the part of the linea alba. As you all know that linea alba is a fibrous band which is present in the midline on anterior abdominal wall, and it is a line where you have the fusion or the side of your both muscles of the anterior abdominal wall merge. And this linea alba is also having a scar, and this scar lies at the vertebral level of L3 and L4. Now this is the umbilicus. So this is the first thing which you have to write down in the exam. Now this actually umbilicus is itself made up of the dense fibrous tissue, because it is a part of the linea alba, and you know that linea alba itself is a fibrous tissue made up of fibrous tissue, and the umbilicus is also the part of the linea alba. The another important thing is that when you will see the umbilicus, it actually represents the attachment site of your umbilical cord on the fetus. So when you have the intrauterine life, you know that in the intrauterine life you are having the two components. One is the placenta. From the placenta you are having a cord which is known as umbilical cord, and here you are having the fetus. And this fetus is connected with the help of this umbilical cord, and this umbilical cord connects at your umbilicus, and this umbilicus is actually the scar in adult life. And this is the place where you have the connection with the placenta. So when you are writing the introductory part of the umbilicus, you have to basically write down these four important lines, that it is a scar, it is a part of linea alba, it is made up of fibrous tissue, and the umbilicus represent the fetal end of the connection of umbilical cord. Clear? Now, these are the very important points which you should write down in your question when you are writing the importance of umbilicus. Now, the points can be more than these which I enumerate here, but I try to cover the most important points which you should write down. First is, we will talk about what is physiological umbilical hernia. Second thing is, there are multiple congenital anomalies are related to the umbilicus, which can be of two types, related to the vitellointestinal duct and related to the allantoic diverticulum. Then there are multiple peritoneal folds related to the anterior abdominal wall, and these folds starts from the umbilicus or they end at the umbilicus. Then we will talk about the abdominal reflexes, which are actually the superficial reflexes, and these reflexes are important in relation to the umbilicus, because when you will see the response of the abdominal reflex, you will see the movement of the umbilicus also. Then you will have Beaver's sign, which is actually the sign seen into the injury of your T10 segment mainly. Then you have the blood supply of the body wall, lymphatic drainage of the body wall, caput medusa, McBurney's point, Sister Mary Joseph nodule, and lastly there are so many multiple important points like surface marking where you have the position of transpyloric line. So first, what is the physiological umbilical hernia? Now when you will have the physiological umbilical hernia, the first thing is that the physiological umbilical hernia is a natural phenomena. It is a natural phenomena. It is seen into the intraembryonic life. Naturally, when there is a result of the formation of gut tube, what will happen? That gut tube now elongates inside the abdominal cavity. But the important thing which you have to understand, that this physiological umbilical hernia occurs because of the lack of space inside the abdominal cavity. So the first question comes is that why why you have the physiological hernia. What is the reason of physiological hernia? The first answer is that there is a lack of space. Now, why there is a lack of space? And there are two reasons majorly. First reason is that there is a enlargement of anterior abdomen, enlargement of intestine faster than the abdominal cavity. So, the growth of intestine is faster as compared to the growth of anterior abdominal wall and the abdominal cavity. So, there is no space. Second thing is that whatever the cavity is available, the cavity is occupied by the developing liver and the kidney. So, now because whatever the occupancy is there, the space is there, it is already occupied by the liver and kidney, plus the space is not creating regularly because the intestinal lumens are growing faster. The intestine is growing faster, so it has to come out and it will be known as physiological umbilical hernia. So, it occurs as a result of the intestine growing faster than the abdominal cavity during the early gestational period. Along with that, the large size of developing liver and kidneys. So, they are occupying the major portion. So, this faster growth of intestine now come out from the abdominal cavity, and this is actually the physiological or the normal finding. So, in this physiological situation, the intestine elongate and move outside. The things when will come outside from the abdominal cavity is known as hernia. So, it is known as herniating of the contents into the base of umbilical cord, and this is known as physiological umbilical hernia. So, when you are writing the physiological umbilical hernia, you should write down these 2 points in bold letters, that the reason of physiological umbilical hernia is lack of the space inside the abdominal cavity for the developing intestinal loops. And why there is a lack of space? The first reason is because the growth of intestinal loops are very faster as compared to the abdominal cavity and abdominal walls. And second thing is that whatever the space is available, it is already occupied by the liver and kidney. So, physiologically, the intestine now want to seek the space, and that is why they protrude into the umbilical cord. Now, this phenomena is generally seen at approximately around the 8th gestational week, 8th week of gestation, and the important thing is that around the 10th to 11th week of the gestation, these herniated loop will re-enter inside the abdominal cavity and the physiological hernia disappears in the fetus. Clear? So, this is not a permanent phenomena, it is a temporary phenomena, and this natural temporary phenomena starts at around 8 weeks and complete by the end of 11th week of intrauterine life. Clear? But the problem is that if this intestinal loop fails to re-enter inside the abdominal cavity, then that baby will come out with the herniated loops of the intestine or abdominal viscera into the umbilical cord, and this condition is known as exomphalus or omphalocele. So, this is the question, what is the exomphalus? So, exomphalus is nothing but it is if the physiological umbilical hernia fails to re-enter or fails to disappear, then it is known as exomphalus. And this intestinal loop, which is remain inside the base of umbilical cord, is actually covered by a membrane, and this membrane consists of the Wharton's jelly, peritoneum and amnion. Clear? So, this is what is the first point which you have to write down in exam about the physiological umbilical hernia and exomphalus. The second thing is about the congenital anomalies related to vitellointestinal duct. So, in this heading of vitellointestinal duct, we have these 4 things which you have to write down in exam. First is the vitelline fistula or fecal fistula. The second is Meckel's diverticulum, which you cannot actually skip when you are writing it has to be there in your answer, and it is the most common congenital anomaly related to the vitellointestinal duct. Then you will have enterocystoma, and the lastly is raspberry red tumor. So we will see first what is vitellointestinal duct. So when you will see the development, when you will go in the embryology, you will find that the vitellointestinal duct is nothing but it is a communication between the two things. What are these two things? One is your primitive midgut, and the second thing is yolk sac. Now when you will see the development, now see, this is your folding of embryo. Now in this folding you will have the gut tube which is present here. Now this is the gut tube. Now this gut tube is having the communication outside the embryo. Now this gut tube is now divided into the three parts. This is known as upper part, which is in the cranial fold, is known as foregut. This is in the caudal part, is known as hindgut, and this part is known as midgut. Now this midgut here is having a communication, and this communication is known as vitellointestinal duct, and this is your yolk sac. Clear? So this yolk sac is basically the source of nutrition in the intrauterine life. But later on what will happen? The placenta will develop. So the major source of the nutrition will be the placenta. So this part will disappear, and you can see that this connection is no more persist in the adult life. So it is nothing but what is this duct? It is a connection between the primitive midgut, this part, and the yolk sac. The midgut extends from the second part of the duodenum to the right 2/3 of the transverse colon that we know. Now what will happen that under the normal circumstances, we are talking about normally, what will happen with this duct? The duct become a thin fibrous band, and this band is later on fragments into the pieces and absorbed spontaneously. Now the persistence of the duct, if the duct will persist, if this communication will remain or the duct will not disappear completely, then it is going to form different kind of anomalies. Clear? So when you are writing about the vitellointestinal duct in the exam related to the umbilicus, you have to just write down these two lines, that it is a communication between the midgut and yolk sac, and it generally disappear as a fibrous band which undergoes the fragmentation and disappear. But if persist, what are the anomalies you have? So the first anomaly is fecal fistula. Now this fecal fistula is also known as the fistula which is persist from the vitelline duct. So the another name comes is the vitelline fistula. Now this fecal fistula is a complete patent vitellointestinal duct. Now in this condition, a direct connection is present between the umbilicus and the ileum, and this may result in the seepage of the bilious intestinal contents or the fecal material from the umbilicus. What does it mean? That you know that you have the anterior abdominal wall, and this is your umbilicus. Now this is your intestine which is present inside. Now these are the intestinal loops which are present inside. But in the intrauterine life, there was a connection from the midgut to this umbilicus, and it is going outside, which is known as yolk sac. Now this was your vitellointestinal duct. But what will happen that with the time this duct is persist, and when you cut the umbilical cord, when you will remove the umbilical cord from the fetal end, what will happen if you will erase this portion? Now the duct is persist and still the fistula is there. So whatever the contents are there in the small intestine, they will come out through this opening, and this is known as fecal fistula, or the bilious material will start to seepage through this opening. So when the baby will born, you will find the leakage of very smell or the material which is having very awful smell. Clear? So this is what is about the first anomaly. The second anomaly is known as Meckel's diverticulum. Now what is Meckel's diverticulum? Now when you will see the intestine, you will find that this is your intestine. Again, you have to understand that this is the lumen of your intestine, and on the lumen of intestine, you will find a small bud-like projection. Now, this small bud-like projection is persist. Now, you know that here earlier it was a duct. Now, this was the duct. Now, this is your vitellointestinal duct. When the regression of the duct occurred, what will happen that its proximal part persists, this remaining distal part disappears. So, what is this Meckel's diverticulum? Persistence of the proximal part. What is the meaning of proximal part? That means the connection of the duct towards the midgut is persist, and it is the Meckel's diverticulum. So, for that Meckel's diverticulum, you can see the detailed video of my. Now this Meckel's diverticulum is related on the anti-mesenteric border. That means the border which is not providing attachment to the mesentery, and the tip of diverticulum may be free or attached to the umbilicus by a fibrous band. So, what does it mean? That here is the anterior abdominal wall. The remaining duct may have the fibrous band from umbilicus to this Meckel's diverticulum. Now, if this type of picture is there, then sometimes the diverticulum will rotate and it will lead to the intestinal obstruction. So, this is what is the second anomaly related to the vitellointestinal duct. The third anomaly is enterocystoma, or it is known as vitelline cyst. Now, what is this enterocystoma? Now, again, you have to understand that this is your anterior abdominal wall, and this is your lumen of, this is your intestine lumen. Clear? Now, where is the connection? Now, here is the vitellointestinal duct connection, which is between the umbilicus and your, so this is your vitellointestinal duct. Now, suppose in this condition, the proximal part of the duct and distal part of the duct both will obliterate, but the center portion will persist. Now, if you will find that in this connection, the proximal and distal parts are fibrous. Now, this part is obliterated, this part is obliterated. Only this red color center portion persists. So, this is known as the cyst, and this cyst develops into the middle portion of vitellointestinal duct. That is why it is known as vitelline cyst or enterocystoma. So, the persistence of the intermediate part, which part? Intermediate part of the vitellointestinal duct, and this is known as enterocystoma. The another and the last anomaly related to the vitellointestinal duct is raspberry red tumor. Now, what is this raspberry red tumor? Now, if in this duct, what will be the part which disappear? Now, suppose the inner portion, the whole inner portion will disappear. Here is your umbilicus on the surface. Now, this is the umbilicus on the surface. But the most distal portion of the duct is persist here. Now, this duct portion is persist, and the lining epithelium of the umbilicus is actually having the epithelium of vitellointestinal duct. So, this is your area. Now, what will happen? Because of the increased intra-abdominal pressure, now this umbilicus, which is generally invaginated area, evaginate. It will protrude outside. So, suppose if it will protrude outside, what will happen? That the position is something like this, and the lining epithelium is here. Now, this is the lining epithelium. So, it looks like a raspberry. Clear? So, earlier it is a invaginated area, but it will come out, or pop up of the umbilicus will take place. So, when the distal part of vitellointestinal duct persists as a deep sinus, earlier it is a deep sinus in the depth of umbilicus, but sometimes because of the intra-abdominal pressure, it will evaginate or pop up outside, and this is actually lined by the epithelium of vitellointestinal duct. So, the discharge comes from the mucus lining of this area, and this is known as raspberry tumor. Clear? So, the first thing which you have to write down under the heading of this is, first is fecal fistula, second is Meckel's diverticulum, third is antrocystoma, and fourth is raspberry tumor. Now the next importance of the umbilicus is the related to allantoic diverticula. Now what is allantoic diverticula? It is actually the part of your urinary bladder. Now again, when you will see the intra-abdominal cavity, now this is your abdominal cavity. Now here inside you will have the developing urinary bladder. Now this urinary bladder develops from the cloaca, and from the cloaca there is a connection, and this connection is going to the umbilicus. Now this connection extends from the urinary bladder to the umbilicus. So this connection is, if remain patent, what will happen that because you have the urine inside this bag, the urine will come out from the umbilicus, and this is known as urinary fistula. So what is first you should know, what is the allantoic diverticulum? Allantoic diverticulum extends from the primitive urogenital sinus, which actually develops from the cloaca, to the fetal end of umbilical cord. Clear? So this is actually connection from the umbilical cord to the urinary bladder, which develops from the cloaca. Subsequently, the lumen of diverticulum obliterate, and this obliterated part of urachus of this diverticulum is known as urachus, which is a question, and this urachus is going to form your median umbilical ligament at birth. So what is the median umbilical ligament? It is a connection between the urinary bladder and the umbilicus. Second thing is, why this ligament form? Because of the obliteration of this urachus, and this urachus is nothing but it is a allantoic diverticulum in the intrauterine life. So if it will persist, if this diverticulum will not obliterate, the urine will come out through the umbilicus at birth. So if it is seen that urine is coming out, then it is known as urinary fistula. Now sometimes what will happen that the urachal cyst is also seen. Now what is urachal cyst? The urachal cyst is that, suppose if you will see this diverticulum, this part will obliterate, but some middle portion will persist, and its proximal and distal both part will disappear, only the middle portion will persist as a cyst. Clear? So this is the another important thing, that urachal cyst is the persistence of the part of the allantoic diverticulum. So this is the important third point is allantoic diverticulum. The next point related to the umbilicus is peritoneal folds. Now peritoneal folds, which are related to the umbilicus, are seen on the anterior abdominal wall. When you will go inside the abdominal cavity, and if you will see from the inside, you will find that peritoneum is showing the folds. So there are two sets of the fold, infraumbilical fold, supraumbilical fold. You will find 5 infraumbilical folds, and for their appearance you can go and watch my video on the umbilical ligaments. These umbilical ligaments, which are infraumbilical, are 5 in number. One is known as median umbilical ligament, which is centrally placed, formed by the urachus. Second is known as medial umbilical ligament, which are right and left, that means paired ligament. They are formed by the obliterated umbilical arteries. Then you will have the one more set of the lateral umbilical ligaments, which are formed by your inferior epigastric vessels. So there are 5 infraumbilical folds. What are the name of the folds? Median umbilical fold, which is having median umbilical ligament, medial umbilical folds, which are having medial umbilical ligaments, and lateral umbilical folds. The infraumbilical folds are these, but when you are talking about the supraumbilical fold, you will have only one supraumbilical fold, and this supraumbilical fold is not in midline, but it is little bit right on the midline, and this supraumbilical fold of peritoneum is known as ligamentum teres, or round ligament of Lever. Now this round ligament of Lever is actually having a left obliterated umbilical vein. So the supraumbilical peritoneal fold is actually the round ligament of the lever which passing from the umbilicus to the lever just right side of the midline. It is not a midline structure, and what it consists? Obliterated left umbilical vein. The next importance of the umbilicus is abdominal reflexes. Abdominal reflexes are superficial reflexes, and these reflexes are there to protect the underlying viscera from external danger. Now, how to elicit the abdominal reflex? We will make the subject lie down, we will make the subject comfortable, we will expose the anterior abdominal wall, and the most important thing is when you will elicit, your stroke will go from outside to inside. That means from lateral to medial side. Now, suppose this is your anterior abdominal wall. Now, this is your anterior abdominal wall, this is your umbilicus, clear? Now, when you are doing the abdominal reflex elicit, your stroke should be from lateral to medial side. That means I am stroking like this. So, you are taking the stroke from lateral to medial or outside to inside. Now, what is the reflex response? A normal positive response is the contraction of underlying abdominal muscle with the umbilicus moving to the side of the stimulus. Now, this is the importance of the umbilicus, why I am taking this abdominal reflex under the heading of umbilicus, because when you will see the response of superficial abdominal reflex, you will find that umbilicus moving to the side of stimulus. That means if I am stimulating from the right side, now this umbilicus will move towards the right side. Clear? So, what is the side of the movement of the umbilicus? The umbilicus will move towards the right side only, along with the contraction of these muscles of right abdominal wall. Clear? These reflexes are absent in the upper motor neuron lesion. This is very important question for your exam. So, this is the importance. Now, there is a Beaver's sign. Now, this Beaver's sign is again used by the monitoring of umbilicus. You can find out the umbilicus is placed in the its original anatomical position in a normal patient, but it moves cranially when you have the injury of your spinal cord, particularly at T10, T11, T12 region. So, that is known as Beaver's sign. So, what is the definition of the Beaver's sign? That abnormal upward or cranial movement of the umbilicus on attempting to raise the head from a supine position. What does it mean? Suppose I am lying down on the couch, and if you ask me to lift my head like this, if a person is lifting the head without supporting your upper arms, so ask the patient to keep upper arms on your chest, and now he should lift the trunk, or he should try to lift his upper part of the your chest, so or the shoulders. So, when he will try to do this movement, you will find that umbilicus is moving upward, which is not seen in a normal person. Why it is not seen in a normal person? So, in normal people, the rectus abdominis muscle of both sides, contract as one unit. There is no prominency of upper half or the lower half or right or left side. That means when I am lifting my shoulders in the lying down position, my both rectus abdominis are contracting simultaneously without any difference in supra-infraumbilicular part or right or left part. So, the supra-umbilical and infraumbilical rectus abdominis are contracting in the same manner in case of a normal person. So, in normal person, you will not find any kind of cranial movement of umbilicus. Umbilicus remain its normal position in that normal condition. But if you have the injury of spinal cord or you have the infraumbilical muscle weakness, what will happen? That the person will have the shifting of umbilicus in upward direction. So, this is the Beaver's sign. So, Beaver's sign means the shifting of umbilicus in upward direction when you are asking the patient to lift the trunk. And This is not seen in a normal person because the both rectus abdominis work as a single unit. Now, the another importance is the blood supply. So, when you will see the umbilicus as a reference point, you will find that the blood supply of body wall above the umbilicus and below the umbilicus comes from two different sources. So, what are the different sources? Above the umbilicus, you will find that there is a branches of internal thoracic artery. What these branches? Musculophrenic and superior epigastric arteries. But where you will see the blood supply below the umbilicus, the source are femoral artery and external iliac artery. Clear? So, first you have to understand that supraumbilical region is supplied by the branches of internal thoracic and the infraumbilical region is supplied by branches of femoral and external iliac. So, what are the branches of internal thoracic? You have the musculophrenic and superior epigastric. What are the branches of femoral? There are three cutaneous branches of the femoral: superficial external pudendal, superficial epigastric, superficial circumflex iliac. And what are the branches of external iliac? You have inferior epigastric and deep circumflex iliac artery. Clear? So, these are the supra and infraumbilical blood supply. Now, what is the difference in the venous drainage in reference to the umbilicus? So, the blood is collected by anastomosing network of the vein which radiate away from the umbilicus. So, this is the one thing that when you will see the venous drainage, the veins are radiating from all around. Now, the important thing is that below the level of the umbilicus, the superficial veins pass to the great saphenous vein, and from the great saphenous vein eventually the venous drainage will take place in inferior vena cava. So, what is the venous drainage? Infraumbilical. Infraumbilical venous drainage will go to the great saphenous vein, and from the great saphenous vein ultimately it will reach to the inferior vena cava eventually. What about the venous drainage above the umbilicus? Now, when you will see above the umbilicus, the venous drainage will take place through the lateral thoracic veins, and ultimately it will reach to the axillary vein and eventually into the superior vena cava. Clear? So, if I am talking about the venous drainage above the umbilicus, it will go to the lateral thoracic vein, axillary vein, and eventually into the superior vena cava. Below the umbilicus, you will have the veins which will go to the great saphenous vein and eventually into the inferior vena cava. But you have the one more set of the veins which are known as paraumbilical veins. So, you have the supraumbilical veins, you have infraumbilical veins, and the third set is paraumbilical veins. Now, these paraumbilical veins are not going in upper or lower part, they are going deep into the anterior abdominal wall. And deep into the anterior abdominal wall, they will run along with the round ligament of lever or ligamentum teres, and along with the ligamentum teres, they will join the left branch of portal vein. Clear? They will join the left branch of portal vein. So, in this way, you have the three sets of the veins around the umbilicus: supraumbilical vein, which will go into the superior vena cava ultimately; infraumbilical vein, they will go into the inferior vena cava ultimately; and paraumbilical vein will become the part of portal vein. Now, because of this paraumbilical veins and the systemic veins, this is the important question comes related to the umbilicus. This is the another importance when you are writing on the short note of umbilicus: caput medusa. What is this caput medusae? It is a paraumbilical vein which is actually, we have seen, is going to drain into your portal vein. So, it is a tributary of the portal vein. It is communicating with the number of tributaries of the systemic vein. What are the systemic vein? I just told you the veins which are eventually draining into the superior vena cava, or veins which are eventually draining into the inferior vena cava. So, superior and inferior vena cava veins are anastomosing with the paraumbilical vein around the umbilicus. So, this will become the portocaval anastomotic site or portosystemic anastomotic site. Clear? So, what are the two components? Portal component, which is paraumbilical vein, and systemic or the caval component, which is the veins which are draining into the axillary or great saphenous vein. Now, in portal obstruction, now you have to first understand this, that what will happen, that this is your lever, and inside the lever your portal vein is entering. Now this is the portal vein which is entering inside the lever, and this portal vein is going to divide into the further veins which will pass through the sinusoids, and from the sinusoids the ultimately blood will come out through the hepatic veins which will open into the inferior vena cava. Clear? Now what will happen? Now suppose there is a portal hypertension due to some cirrhosis or tumor or whatever the malignancy is there. So the blood which is passing through this portal vein is now not able to reach the inferior vena cava. This blood is now not able to reach to the inferior vena cava. So in such condition, this blood is now looking for a alternative route. Now what is the alternative route of circulation? Now this blood will start to come out from the para-umbilical veins which are actually connected to the umbilicus, and these para-umbilical veins are anastomosing with the number of veins which are systemic veins here. So now this blood which is approaching the umbilicus will pass through these veins which are systemic veins, and these veins are radiating all around the umbilicus like the spoke of your wheel, and this is known as caput medusa. So what is the important line to write down the caput medusa? That in case of the obstruction of this portal blood, the blood which is coming from the alimentary tract now is in search of alternative route, and the alternative route is portocaval anastomosis. So these routes ensure that the venous blood from the gastrointestinal tract still reach the heart through the vena cava without going through the liver. Why without going? Because now there is a obstruction in the liver due to any malignancy or the cirrhosis that is creating the portal hypertension. So the subcutaneous tributaries of systemic vein around the umbilicus are now shows the distension, and this distension is spread like the spokes of the wheel, which is known as caput medusa. Clear? So this is the another importance of umbilicus. The another more importance of the umbilicus is the lymphatic drainage. Now again you will see that the lymphatic drainage above the umbilicus and below the umbilicus. So above the umbilicus, the lymphatic drainage is divided into the two parts, superficial and deep. So superficial lymphatics above the umbilicus will go into the axillary lymph node, and superficial lymphatics below the umbilicus will go into the superficial inguinal group of lymph nodes. If we will talk about the deep lymphatics, you will find that above the umbilicus, deep lymphatics will go into the mediastinal group of lymph nodes after piercing the diaphragm, and the deep lymphatics below the umbilicus will go into the pre-para-aortic group of lymph nodes and external iliac group of lymph nodes. Clear? So this is the importance of umbilicus in relation to the lymphatic drainage. Then you have one more importance is McBurney's point. Now what is McBurney's point? Now when you will see the anterior abdominal wall, now this is your anterior abdominal wall, and on the anterior abdominal wall, if you will draw the bony landmark, this is your chest wall, and here you have your inguinal ligament, and this is your umbilicus. Now from this anterior superior iliac spine, which is here where you have the spines, you can see the projection. Now from this ASIS, if I will draw a line, this line is connecting the ASIS and umbilicus. Now this line is divided into two parts, 2/3 and 1/3. So the McBurney's point at the junction of medial 2/3 and lateral 1/3. So where is the junction? This is the junction, is the junction. So this is the medial 2/3 and lateral 1/3. At this point, the patient of appendicitis is having maximum tenderness. So this is the point of maximum tenderness in acute appendicitis. So to identify the McBurney's point, you have to require the landmark of umbilicus. So surface marking of McBurney's point require the umbilicus. That's why we include the McBurney's point under the importance of umbilicus. The next point is Sister Mary Joseph nodule. Now this Sister Mary Joseph nodule is a very rare findings of intra-abdominal organs malignancy, and some malignancies will show a metastasis of cancer cells, and those cancer cells will come and form a nodule at umbilicus. So if a malignant metastasis will take place around the umbilicus, there is a nodule is seen, and this nodule is a sign of malignancy of abdominal organs like pancreas, like pelvic organs. So this is known as Sister Mary Joseph nodule. Then the next importance is there are so many small surface marking points which you can include in this question. For example, what is arcuate line? Now when you will see the rectus sheath, you will find the posterior wall of rectus sheath is not complete. Now the midway between the umbilicus and the pubic symphysis, you will find that posterior wall is having the arcuate line. So below the arcuate line, the posterior wall of rectus sheath is made up of fascia transversalis only, and anteriorly all the three muscle aponeurosis will come. So that is you can include, because if you want arcuate line, you have to use umbilicus as a landmark. So what is arcuate line? It is a horizontal line midway between the pubic symphysis and umbilicus, and again we are using umbilicus as a landmark. So you can include this also in your question, the importance of umbilicus. The another importance of umbilicus is that you have the position of transpyloric plane. Now what is transpyloric plane? So the distance between the umbilicus and xiphoid process. So this is your xiphoid process, lower end of sternum. This is your umbilicus. So almost midway you have this transpyloric plane. So transpyloric plane approximately midway between your xiphoid process and the umbilicus. So again we are using umbilicus as a landmark, and it lies at the level of L1. Clear? So what is the level of transpyloric plane? L1. And what is the level of umbilicus? L3, L4 intervertebral disc. Now the another importance is that you can write down the three intertendinous section of rectus abdominis. And how we'll count the three? Again we are using umbilicus as a reference. So the lowermost third intertendinous section of rectus abdominis lies at the level of umbilicus. So the lowermost lies at the so they are formed by the tendinous intersection in the rectus abdominis muscle. Clear? So there are multiple things which you can write down in this importance of the umbilicus. So once you will finish the abdomen, you will realize that there are n number of things which you can include based on your knowledge. So I try to include most of the important aspects in the importance of the umbilicus point, because it is a very commonly asked question. So you will start writing from its introduction. You can write down what is physiological umbilical hernia, what is exomphalus, what is the congenital anomaly of umbilicus related to the vitellointestinal duct, related to the allantoic diverticula, what are the physiological, what are the peritoneal umbilical folds related to the umbilicus. Then you can write down what are the surface landmarks related to the umbilicus, like McBurney's point, like transpyloric plane. Then you can write down what is caput medusae, the blood supply of anterior abdominal wall in relation to the umbilicus, lymphatic drainage of the your anterior abdominal wall in relation to the umbilicus, venous drainage. So there are so many things which you can include in this question. So this is all for today's class. Thank you.